Hello and welcome to the Public Health Spotlight podcast, brought to you by Panoramic Associates and partnered with the ADPH. Today I'm really excited and joined by the Director of Public Health of Gloucestershire County Council, Siobhan Farmer. Siobhan?
Hi.
Lovely to have you on the podcast. Really excited to have you on here. We'll just dive straight in, if that's okay. So we just want to touch on the start of your career. So you studied physiology at the University of Liverpool before pursuing a master's in public health. Please talk us through that. Firstly, what got you into public health in the first place?
Yeah, so the physiology degree was great. I really enjoyed it. But I think I decided that being in a lab all day probably wasn't for me. I'm possibly a little bit too extrovert to not speak to anybody for several hours, and some of the lab work was quite isolating. And I've got great respect for anybody that can do that, really. But so I ended up doing a more public-facing research project looking at back pain and fitness, and understanding the relationship and why some people who are very fit physically still have back pain. But the bit I enjoyed the most was actually talking to people about what they did for fitness and how they stayed well and how they stayed healthy, what their barriers were. And the more I looked into this, the more I worked out this was actually something called health promotion or health improvement. And so I started to look for roles in that sector, explored some generic health promotion roles at the time, and ended up looking across County Durham and Tees Valley. I was living in the northeast at obesity in children and young people, and trying to understand whether or not children and young people were living with obesity more than in previous decades. I think there was a suspicion that they were, but we didn't have any evidence because there wasn't a national weighing and measuring programme at the time. And the work we did strongly recommended that there should be both a weighing and measuring programme, but also support to help children and young people maintain a healthy weight. And interestingly, we do now have a national weighing and measuring programme for children, but we don't have the same expectation around support for children with obesity. So that's very much the work of the local public health teams, actually, to make sure that we can help children maintain a healthy weight throughout their childhood.
Nice, thank you. What were the first couple of roles you did before or alongside your registrar training?
Yeah, so as I say, I was in the health promotion sphere for a while, actually. So after doing that piece of work in Durham and Tees Valley, I was then working in young people's health promotion in Hartlepool and then subsequently Redcar and Cleveland. So it was very much healthy schools at the time. And some of my work, particularly in Redcar and Cleveland, was sort of marked by the Jamie Oliver series, which many people listening are probably far too young to remember. But there was a particularly famous scene on the Jamie Oliver programme, and he was famous for trying to get turkey twizzlers out of school. And a famous scene where the mums were posting McDonald's through the school fence. And my job at the time was actually to work with the schools on their healthy schools and healthy food policies. So to look at working with children and young people, co-designing their cafeterias and thinking about the menus, thinking about vending machines, helping them to understand what eating healthily was like. But healthy schools was much wider than that. It also looked at personal, social and health education. So things like sex education. Some of the areas we were working in had quite high teenage pregnancy rates. So looking at making sure that they had access to advice and understanding of the risks, and making sure that they could access contraception, etc., if they needed to. So I did that for a few years over in the northeast, and then moved back to the northwest where I grew up, and did the same kind of work in St Helens, but moved more into looking at drugs and alcohol use and supporting children to minimise their use and to get support if they were using through local services. And I was thinking about, what do I do next? What career do I go into? And somebody mentioned the public health training scheme. And the more I looked into it, the more I understood that they were the people that commissioned things like drugs and alcohol programs or sex education programs. And at the time, public health was in the NHS. And obviously I'd been working in local authorities, but had had a bit of NHS experience doing the back pain project. So it felt kind of a natural fit. Yeah, so I applied for the training scheme, which is a national process, and I think I was the first year that they did the full assessment centre, which is now online, I think, which must be really unusual. But yeah, so I was the first year that went down to Loughborough, it was at the time, and you go around like a carousel of interview stations, and it's quite intense. And you do some group work and a written exercise. And yeah, I was successful, got on the training scheme, and yeah, 5 years of training in the Northwest.
Lovely. Just before we touch on that,
Yeah.
I'm quite intrigued. Leaving university, doing your masters, and then seeing quite, I would say, hard hitting, if you don't mind me saying, hard hitting stuff around sort of like health, obesity, drug, alcohol with young children. And you're young yourself, right? What perspectives did that give you? How did that sort of allow you to sort of see the world maybe in a bit of a different sort of, yeah, a different view?
Yeah, I mean, I think I, what when you apply for public health training, you're asked to talk about what motivates you, and I'm so sure somebody's probably going to steal this answer now, but go for it. I have always really felt it's kind of wrong that we live in a society where we've got such affluence and such, relative health, and it's a great country to live in. Most people are very well and have a good job and a good income. But that's most people, not everybody. And when you read into it, you look at places. I think I did geography at GCSE, and we actually did a study on Glasgow at the time, and the way that the centre of Glasgow had become very deprived and the population had moved out to the kind of more affluent outskirts. So it's interesting, actually, geography isn't that dissimilar in many respects in terms of it's that kind of study of people and populations, and that's very much a skill that we do in public health. And I remember learning that I think that our life expectancy in central Glasgow at that time was, I think about 54, something like that. So in some parts of Glasgow, people were dying younger than the average life expectancy in parts of Africa. And that, I think that just sort of blew my mind really and made me think, well, this country is very unequal. And then that's what you see play out when you actually work with communities. You realise that things aren't equal.
Yeah.
People don't have the same opportunities in life, and it's not just as simple as saying, "Oh well, the opportunity's there for a job. Off you go and get it." You have to have grown up in the right area. You have to have parents that can support you outside of school. You have to have education that's good, and not all schools are equal. We know that. So I guess it was just my real awakening into inequality and
Yeah.
how, as a society, we've got to think about how we make things more equal for people.
Yeah.
And then there's a whole master's discussion about equity versus equality. But I think, it really opened my eyes to, not everybody is born with the same life chances in our country,
Yeah.
let alone globally.
Yeah, really interesting. We've not heard that perspective before, which is really good. Thank you. So yeah, talking around the training scheme, obviously you worked, I think it was in Merseyside, Cheshire, and the Health Protection Agency.
Yeah.
What was your experiences like there? Were there any main ones there or projects, programs of work that you worked on that, yeah, really sort of stand out to you and sort of took you forward into being a consultant?
Yeah, so Cheshire and Merseyside. So when I started my training, as I say, public health was in the NHS. So I was working in primary care trusts initially. During training, you can pick up specialist placements, and at that point, health protection sat with what was called the Health Protection Agency at the time. And I was really interested in the Health Protection Agency work because when I was in, I think it was Holton and St Helens both have quite a lot of contaminated land from previous industry. So St Helens is a strong glassmaking area, and Holton was the place where the ICI factories, a lot of ICI factories were. So a lot of contaminated land, which then has to be remediated before you can build on it in order to safeguard the population, which is obviously quite right. But it's really fascinating in terms of protecting the health of the public. So I got really interested in that environmental public health side. But I was also interested because I did physiology in disease, diseases and communicable disease in particular. So the health protection side spoke to me as well. So I took a specialist placement. Again, you have to apply at Cheshire and Merseyside Health Protection Agency. And yes, we did some contaminated land work there. That was really interesting. But I think the thing that stood out most of all was I must have been there about 6 months, and we had first case of measles, I think, that the England had seen for, it was a long time, maybe 10 years at that point. And there's been quite a lot of measles outbreaks since then, but that was particularly kind of one of the first big outbreaks we've seen in this country for a while. And it, I don't know how much people know about measles, but it's one of the most infectious diseases we have in the world. And if you're not vaccinated, you are fairly likely to catch it if you're in the same room as somebody. So yeah, very, very infectious. And vaccines are the best way to protect against getting it. Clearly, some people can't have vaccines because they've got conditions that mean that their immune systems don't work as well. So that if you give them a vaccine, it doesn't necessarily protect them in the same way. So we rely on a lot of the population having had the vaccine to protect those who can't, or the very little babies that are too young to have the vaccine.
Yeah.
But so what we ended up with was a situation in Merseyside where vaccine uptake rates had dropped off. So there was quite a lot of what we would call susceptible people in the population. So measles spread.
Yeah.
And we had a lot of cases. I mean, again, I can't remember the figures, but I think we're looking back at the end of the outbreak, which went on for well over 12 months. I think we'd had something like 600 confirmed cases at the time. I mean, somebody will probably say that's wrong, but it was 600 cases. I remember the figure being something like 1,800 suspected cases. It was a lot of people. And what you have to do is you have to ring up. You have to speak to the person or their family. You have to find out where they've been, who they've seen. And the thing with measles is it's infectious before you get the rash. So you have to work out where they've been for the last 5 days, do that, what's called contact tracing. And then you have to contact those people to say, oh, you've been exposed, and are you maybe pregnant? So do you need some support? Do you need an injection to help your immune system fight the virus? So yeah, fascinating. A lot of work, very in depth, really understanding about disease control, and working with people who may be quite anxious about having been exposed, and maybe aren't particularly pro-vaccination, for example, and having to work with them to help understand why they might be worried about getting the vaccine if they've not had it, and that sort of thing. So yeah, really fascinating learning.
Yeah, definitely probably one of the biggest moments in your early career.
Yeah, definitely.
Was it like one of the most how can I put it? Just like not a proactive, whereas like as soon as the outbreak came, I can imagine it was quite urgent. Well, it was urgent panic rather than, trying to deal with, like you say, healthy living and drug misuse and things like that. When an outbreak comes, I can imagine the situation, the environment around you and the people around you, the urgency just changes quite quickly.
Yeah, absolutely. So for measles, if you've been exposed and you're pregnant, for example, or you're what we call immunocompromised, so your immune system doesn't work, and there's a few other examples where we think you were at risk of having been exposed. You've got a very limited time window to get an injection into somebody, and that injection is called immunoglobulin, and the immunoglobulin helps your immune system fight the virus. But that time's really limited, so you've got to act quickly. And the risk, measles can kill. And I think because so many people are vaccinated and we see so few cases, people have forgotten that. So it is a dangerous illness. So we do need to act quickly to save lives. And as you can imagine, if you think about, well, if I asked you where you've been over the last 5 days, number one, would you be able to remember? And number two, how many places have you been where there's, 40, 50, 100 other people? If you've got on a train, we're never going to be able to find everybody on the train. So then we have to think about overall public messaging. And we have to say to people, if you haven't had the vaccine, get the vaccine quick. Because if you've not been exposed yet, you might be. So please get some protection. So yeah, it's very, very reactive. It's very urgent. And I think it's absolutely important that we don't panic and we think very carefully about planned procedures we've got, and everything is in a protocol. So, we plan for these situations, we test the plans, we understand, but ultimately you can't prepare for how humans behave and who they see. And, and if you get an outbreak in a school or a nursery, you can imagine dealing with kind of anxieties, quite right, anxieties and concerns, and listening to parents and trying to understand. And sometimes, some of the children that were infected, well, adults as well, would be very, very sick and in hospital.
Yeah.
And the reason people don't die from measles so much anymore is because our healthcare is so much better. So if you do end up in hospital, the healthcare you get is miles better than it was 50 years ago, just because of technology and machines and science moving on, and our doctors being amazing. But it's still really frightening to have a relative or a child in hospital, and then having somebody from the Health Protection Agency saying, "And who else did you see?" So yeah, just trying to be really mindful of people's reactions, and but a lot of the other routine work went to one side.
Yeah, definitely. Thank you for sharing that. Really interesting. Then moving on for your training scheme, your first consultant role in Salford City.
Salford.
Yeah. How what drew you to Salford? And then if you could talk us through the portfolio and any sort of projects that you worked on there that really stand out, would be amazing.
Yeah. So Salford, well, I guess at the end of any training scheme, there's something about, where the available jobs are, and also then making sure that you meet the Director of Public Health and you see if you might be a fit for the team, and the Director of Public Health at the time, welcomed a conversation. We had a discussion about what the portfolio might be and what the team was like, and learned a little bit about the city. And there was an opportunity to sort of act up before there was a post available. So that was really good to get some experience. And I think the important point is that I mentioned when I started my training scheme, public health was in the NHS, but I was doing it between 2009 and 2014. And in 2012, 2013, public health moved into local authorities. So for me, actually, although I had done my health protection experience, I was quite excited about going back to local authority because I'd done a lot of my work with schools in the local authorities across the region and in the northeast. So it didn't feel that unfamiliar to me, and I sort of knew how local authorities worked and I knew how to work with politicians. So that was actually quite good for me. It was a good opportunity. And Salford's quite a small local authority. At the time, it's about quarter of a million people. It's bigger now, but it had quite an exciting vibe about it, and it was doing a lot of regeneration. And what was really cool about their regeneration was that they weren't decanting their population elsewhere and then building nice buildings. They were developing the brownfield site of the Quays, which was old industrial land. But some of their more deprived areas, their social housing, they were redoing the social housing and moving the population from the existing social housing into the new social housing, and then redeveloping the old social housing area. So they were keeping communities together. It was quite innovative, actually, I think, at that point, and really good to see that kind of strong community belief, and that's sort of nestled through Salford City. They have and they still do it now. They have a little heart pin badge, which is called the Spirit of Salford, and they celebrate their staff for showing the spirit of the city. And it's kind of Manchester's little neighbour. And if you tell anybody in Manchester, anybody in Salford, that Salford's in Manchester, they get very upset.
Well, either.
And Salford is, I don't think you said it, so it's okay. Salford was actually established as a city before Manchester. Many people don't know that. So, that's very strongly held there. And it has a lot of history and tradition. It's famous for Lowry and various other things over time. I think is it the Vimto factory, I think, is there as well. So there's some really interesting history to it, and it's just a very proud place to work. So it was great. It was a really good first consultant job, and to really work with communities and understand their neighbourhoods. And it's got a lot of different areas, a lot of different character. But equally, we talked a little bit before about sort of the challenges and opportunities. Quite a lot of deprivation, quite a lot of need, which is very deficit focused. And you can see how much I love the city and how passionate I am about the people, because that's what it's really about. It's about, actually, there's huge assets there, and it's easy to concentrate on the have not rather than what they have, and there's loads going on. But I think it's about making quite a strong case to government for the investment that's needed to to bring up the area and give those opportunities to people.
Nice. And what was the portfolio that you took on? And
So I led on, well, it was 4 years there, so various different things, but I led on intelligence, but that also included looking at the data for the whole council. So using that data to understand those areas of need and where things were strong and where things needed more work. I led on sexual health, which is fascinating because, of course, Manchester City Centre, huge, well, Canal Street, very well known, obviously. So quite a large LGBTQ community that doesn't just live in Manchester, but lives across all of Greater Manchester. And that's quite interesting in terms of the way we commission sexual health services, because you can access sexual health service no matter where you live. So if you go out on a night out in Blackpool, you can go to one of their clinics the next day, and then you charge that visit back to the local authority where you live. So it was fascinating trying to unpick the kind of what we call cross-charging between the areas to understand, what people did and how we could therefore use kind of support in the right places at the right time for our residents. So yeah, interesting. Yeah, and then I did mental health for a little while. Worked on various different commissioning. I led on NHS Health Checks as well, which is a mandatory programme. Everybody aged 40 to 74 should get a health check every 5 years. Delivered differently in parts of the country. So.
nice. So really good 4 years.
Yeah.
You look back on it fondly, you can tell.
Yeah, I really, really miss the team so much, and I lived in Salford as well, so yeah, it'll always hold a
Special behaviour. And then from Salford, you went to the Greater Manchester Health and Social Care Partnership.
That's right, yeah. So that was the first example where NHS England gave the money to a region to manage, rather than managing it from the centre. So, and it was a forerunner of the latest NHS change, from clinical commissioning groups into integrated care boards. So it was sort of an integrated care board, really. It was a partnership of 37 health organisations across the city, the city of Manchester and the surrounding 10 local authorities working together to deliver good quality healthcare.
And what was sort of your role there, and how was the transition from Salford going into that role? What key experiences did you take away from that?
Yeah, so I was doing a role. It would normally sit with Public Health England at the time, which is again another agency that's reformed since. There's a theme here about change. But we so I was employed by Public Health England, but I sat with the team in what was effectively the NHS team. And my role was to look at the public health aspects of screening and immunisation. So you can probably tell from the measles outbreak, I got quite an interest in vaccination, and I'd always had quite an interest in screening from my training as well. So it was a really good career move for me to learn more about how we commission screening and how, so that's things like breast cancer screening, bowel cancer screening, abdominal aortic aneurysm, if people know about that. So it's looking for amount of deformity in the stomach area that can rupture and cause death. So quite serious again. So again, we can screen for that. So really interesting. And also the bit people don't realise about screening is the programmes we have for unborn babies and newborns to look for deformities in babies as well. So yeah, screening program. So if you ever go through that with a partner, then you'll see all the tests that we do for babies. So yeah, it's a really, really fascinating line of work. I also worked on NHS Health Checks across the whole of Greater Manchester then, and we were looking at whether we could do some of it digitally. And we also looked at the introduction of a lung health screening program or lung health check program. And that was quite interesting because the public health angle at the time was that the benefits of screening using the lung health check program weren't necessarily outweighing some of the risks. And so it's always a balance. And some of the risks were whether or not we were going to be causing anxiety or worry about something that then would turn out to not be cancer. and whether or not we were doing it equitably, so who we were offering it to. So yeah, the idea is that we would screen people who'd smoked to see whether or not they had early signs of lung cancer, and then they can get an operation. But that only works if you've got enough people to do the operations and you've more people to do the screening, and that you can actually offer it equally to the population. So those were some of the things we were looking at, making sure were built in. More recently, the National Screening Committee's announced that it should be a screening programme, and it's being rolled out in patches across the country. So interesting because people naturally think it's a really good thing to do, which of course it is. But we have to remember that sometimes harms can come from some of the procedures we go through.
Yeah, no, 100%. Thank you. And then we go to Gloucestershire. Joining in 2020.
Yep, January.
Do you remember it?
I do. 7th January 2020.
How was that as a start of your career at Gloucestershire?
Yeah, so I came here to be Deputy Director of Public Health. I moved down from the north. You can probably tell, still got the generic northern accent. But I wanted to experience a different part of the country. The health challenges here are very different. You can tell probably from the career history. I've worked in a lot of urban areas that have ex-industrial areas where they've kind of got the second, third generation unemployment because the industry's gone, and kind of the challenges that creates. But Gloucestershire is completely different. It's huge. So compared to Salford, which you could probably get across by car in 20 minutes if there wasn't much traffic, you're talking an hour and a half each side, from one side of Gloucestershire to the other, north to south. We border with Wales on one side, Oxfordshire on the other. So, it's massive. And with that comes a lot of rural communities. But we also have some quite densely populated urban areas as well, like Gloucester City, where we're based. So yeah, very, very different area. And I wasn't quite sure I wanted to be a director of public health yet. And because it's a bit of a bigger place to work, there was the opportunity to be a deputy.
Yeah.
Which doesn't happen in smaller unitaries always. So I thought, well, I'll come down and try my hand at being a deputy and see how that works, and learn from somebody who's a really strong DPH. They're very well respected. And the consultant team were really happy working with her, which is always a great sign. So my job was to come in and to support Sarah Scott. So she was the previous DPH, was to support Sarah in her job so that she could do much more of the strategic piece. I was going to then sort of manage the business of the team and support the team. And I was going to do 1 day a week of health protection. And I mentioned before, a lot of the health protection work is planning and preparing, and not reacting in a local authority. But yeah, that sort of changed. So by the end of February, I think we were the 10th. We had the 10th case of COVID in the country, and with the 10th one to be declared. We were straight into incident response and trying to understand what we needed to do and how we needed to support the person who'd been diagnosed, but also how we would protect the wider public from this novel disease, this unknown coronavirus at the time, before we started to fondly call it COVID. And I was actually packing boxes at my house in Manchester and dialing in, not using Teams. It's amazing actually, 5 years. Yeah, old school. I think they still had the spider thing on the desk in police headquarters at the time. So yeah, I was dialing into a teleconference with boxes around my ankles, to hear Sarah chair the teleconference about the case and what we were going to do next. And that was the start of, at least 18 months of very, very intense work, pretty much solely on COVID. And we had to really pause a lot of the day-to-day work that we do in public health, or some of the team valiantly kept it kind of ticking over, but without much development or innovation. A lot of the things we do, so sexual health drop-ins, they stopped. NHS Health Check was stopped. So a lot of the activity we would normally do to help people stay well was paused while we dealt with COVID.
So at the start of your career, when you had to deal with the measles outbreak, how did that experience set you up for COVID and add in value to Gloucestershire straight away?
Yeah, so because health protection's a specialist placement, all trainees in public health do 3 or 4 months, depending on where they are, in the health protection team, which is now sitting with UK Health Security Agency. And from there, you can decide whether or not you want to do a specialist placement or not. But a lot of people say this isn't for me. And quite often the people that say it isn't for me don't do a specialist placement and will end up working in local authority because they like the planning, the preparing, the health improvement piece, the bits we do with our NHS partners, and they don't necessarily like the reacting piece. So I'd come into a team where one of my consultants, who is no longer here, but I know she probably wouldn't mind me saying, really didn't enjoy health protection at all. And I think the dawning realization of the consultants that this is what we're going to have to do now. And of course, we're trained for it and, we keep our competence ready. But I think, it, it's not, I think it does keep people awake at night in, managing COVID and or something like COVID. And luckily, I think for all of us in the country, although clearly it's really sad many people did pass away, it was a disease that we learned quite a lot about quite quickly and were able to get tests and were able to get a vaccine. And so we were able to combat it. But of course, that's not always the case with communicable disease. So, I think we were sort of a lot of the first few months and learning from the measles outbreak was that bit about the communication and understanding those anxieties and those fears, and trying to make sure that the messages were clear and trying to manage some of the fear that was in our communities and supporting those who were vulnerable and isolated and making sure that those that we knew couldn't go out and be exposed could get food. Um, Whereas the kind of bit about how the virus is spread and all of that is done by UK Health Security Agency, and then we learn that from them and apply that to our work at the local level. So I think having the understanding of how UK Health Security Agency was Public Health England at the time and then became UKHSA, were managing that piece, and then knowing what my role within that was, and then being able to help the team understand that and make sure that we had the right protocols to record and remember what we'd said to who at what time. And dealing with some really vulnerable situations on the front line, like a homeless person who got COVID and was really, really unwell, and making sure that they had somewhere to be while they were unwell. Those sort of real difficult cases that we actually saw in our community. Some of the stories you get, working with care homes, working with some of our care home workers. Being on teleconferences with them and them saying, we've got an outbreak amongst our older people, and them saying, oh, I've been exposed. Well, I may as well just live here for a week because I can't go home. Because if I go home, they're all ill. I've already got the virus, so I may as well stay and care for them. I mean, that's just incredible. And hearing some of those people on the calls and how upset they were, and when their residents, the people that they were caring for passed away, and incredibly traumatic. And public health wasn't on the front line. It wasn't in the hospital. It wasn't doing the job doctors were doing, which clearly, and the nurses, clearly incredibly challenging seeing people sick in hospital. It was a different pandemic. It's the sort of thing that we're all in the same storm, but we're in different boats. And I think it was a different boat, but it wasn't any less choppy for people in public health. Yeah.
Yeah, just a different wave.
Yeah, absolutely.
Yeah, no, thank you for sharing. But yeah, I think, from your experience and in coming into the job, being able to add value, I think, to the team and be able to sort of probably be that calm and have all that experience that you can sort of lean on and help the team,
and
help Gloucestershire.
And knowing what I needed to do, I think, because the measles outbreak, I just I instinctively knew what I needed to do.
Had the confidence to run with it and lead with it.
Yeah. But then I think when we've chatted before, I said some of the downsides of that are that you're going straight into a leadership model, which necessarily is what we would call command and control. So Sarah is the Director of Public Health. She's the person responsible for the health of the population in a pandemic at the local level. And she needs to make sure that the agencies are doing the things that we need them to do to keep the public safe. And as her deputy, I was often given the responsibility to do that on her behalf. So challenging people and saying, no, I need that sooner, or speaking to the fire service and saying, I need you to set up a testing centre for me. Can you go around the county and find me a space where we can erect 15 tents that the DHSC the Department of Health and Social Care are going to provide? Where have we got? What land have we got? I think the fire service was sitting there going, we normally put out fires, and now we're going around looking for, car parks. So, fascinating that we all just sort of did what needed to be done.
Yeah.
But I had to be a little bit more command and control in that than would be my normal style. I'm normally very collaborative, and I do things by consensus rather than telling people what to do.
Yeah.
So quite unnatural. But again, from the measles outbreak, we had some experience. I had some experience of that. So it didn't feel, I think it didn't feel unnatural to do it. It felt unnatural to do it in a brand new place where I didn't know anybody, because I was very worried people might think that was how I operated normally.
All the time. And who have we brought in? But no.
It's a very, very authoritative person that tells people what to do. But I guess that's what being a public health leader is about, is the ability to adapt your style depending on the situation.
No, definitely. We're still here, so that everyone knows you're not like that. Yeah. So bring it to 2022. You did a pharmaceutical needs assessment with Povsmead. I thought when we spoke previously, it was such a really good example of what you've done. So if you could talk us through it, we'd really appreciate it.
Yeah, so the pharmaceutical needs assessment, or PNA, is something that we have to do in public health teams every 3 years, and it looks at the services that are provided for pharmacy across your area as the Director of Public Health. It's usually quite it's a very data-driven exercise. You look at where the pharmacies are, what services they provide, and whether people can access them. And the idea is to look at whether or not there's sufficient access for the population. And you can use a range of different measures to look at that. So walk time, drive time, etc. So we initially did our report, and it goes out to the public for consultation. And you work quite a lot with NHS England nationally, because they have kind of rules around how this needs to be done. So it goes out for consultation, and we got some feedback from people in the Podsmead area, and also the MP's office contacted us to say that Podsmead's an area of Gloucester, not far from here, quite a lot of need, and we talked about kind of areas of deprivation, which can sound pejorative, but it's the way we would describe it in terms of the need it has. And the MP's office got in touch, and I had a conversation with the assistant, and she's called Jenny. Jenny and I had a long discussion about Podsmead, and she said that she felt that there was a gap in Podsmead, even though our data said there wasn't. And so we looked at the data with her, and she said, yeah, but you've said that people can walk to a pharmacy, but the pharmacy they've got to walk to is over a main A road. So your map says it's a 10-minute walk, but what the map hasn't taken into consideration is that they can't cross the A road if they're in a wheelchair, or they've got a buggy, or they're older, because there's no crossing. Oh, okay. Well, we hadn't thought about that. And also, you've said about drive time, but hardly anybody in Podsmead owns a car. So have you looked at public transport? Have you looked at, whether or not people can actually drive there or not? So it gave us a fresh perspective, I think. And obviously that was because of Jenny's work with the community. We had the other survey results in that had said similar. So we decided to make sure that we really checked this out. We had another area of the county who also said, well, we need more access, but they actually did have a pharmacy in their area. So we worked with our data team, and we re-looked at what indicators we could use, and we built car ownership, for example, into our analysis. Yeah. And once we added a few more variables into our analysis, we were able to show there actually was a gap compared to the rest of the county. So NHS England accepted that recommendation, and then the pharmaceutical needs assessment gets published, and then pharmacies can apply if they want to open a pharmacy in an area where there is no provision. They can't apply if there's lots of provision, but if there's no provision, they can say, oh, well, I found a building, I want to open a pharmacy. So that did happen, and there was a procurement process that NHS England went through. These things take a very long time, and we found out that the first pharmacy in Podsmead was opened a couple of weeks ago. So the population of Podsmead now have a pharmacy within walking distance that they can get their medication from, and they don't have to cross a busy A road. So yeah, really, really proud moment actually, because it's one of those things that's a routine thing we have to do, and sometimes can feel that we're going through the motions and that it's not really going to make a difference to communities. But because we were willing to listen and work with and collaborate with the community and their representatives, and again, I think it shows the role of the elected officials there as well, and their ability to campaign and advocate for their local residents. So yeah, really proud moment to see that open, and yeah, delighted.
No, definitely. And I think where we live in a world now where data-driven decisions are literally just thrown at everyone. No, the data says this, so you need to do that, and not necessarily listen to people, how they feel. That's like a really good example of actually the people said it was, the community said, actually, there's something not right here. Look at the data. The data's not always right.
Yeah.
It's not always right.
Or the data we'd picked wasn't right.
Yeah.
So there was more data, we just hadn't used it properly.
Yeah, 100%. To then get a different outcome to impact Podsmead in a better way. I also want to talk about a very impactful program that you've worked on specifically around Just Another Drop. So you obviously written an annual report, and you sent the link, the video, to myself and River, and we watched, and it moved us. And we want to say thank you for sharing it. But for people who haven't seen it or read the annual report or watched that video, please could you just talk us through it and just share it with us, because it's huge.
Yeah, sure. So one of the things we talk about quite a lot in public health is we've got a drugs and alcohol service, but we tend to focus on the drugs part of it, so opiate recovery, etc. And I think alcohol gets less focus because it's a social drug that's it's not illegal, it's legal. Everybody can, over 18 obviously, can go into a pub and buy a drink. But it has a lot of impact in society. And I wanted to think about how we could do more on alcohol locally. I didn't think we had as strong interventions locally as perhaps some other areas of the country did. It's also quite interesting in the patterns of drinking. It doesn't necessarily correlate in the same way as some of our other diseases do, which tend to correlate with areas of more need. But alcohol, everybody can use it in society, so we can see quite a lot of hidden people with alcohol problems that are, what we would call functioning alcoholics. And I have experience of that because my mother was a functioning alcoholic, and in fact she was a head teacher of a special needs school, and yet was drinking a lot in the evenings. And her drinking gradually got worse throughout my teenage years. And the report, the video I did, tells my mum's story and tells the story of how her alcoholism had an impact on both me and my brother and our wider family. And I think coming from that place of understanding, and we also talk about something called adverse childhood experiences, which is experiences that happen in childhood that impact upon us as adults. And an alcoholic parent would be an adverse childhood experience, as would divorce, and my parents got divorced as a result of it all. So I'd lived through quite a lot of those adverse childhood experiences, but I'd managed somehow to maintain my resilience, and I still managed to get myself to uni. I still managed to get my grades, and I managed to do a degree and end up where I am. And but I really wanted people to know that I wasn't being preachy or saying don't drink, or this is a forbidden thing to do, or demonize alcohol. But I wanted to recognize that it's incredibly complex for people, and that drinking is part of our society and part of our culture, and it goes back hundreds of years. In fact, there was a time when people used to drink weak beer in London because it was cleaner than the water. So it's not something that's easy to just say don't do it anymore. And I mean, there's probably parallels with the tobacco story, and we a lot of people used to smoke, and then we realized how harmful it was. but we're not, we're nowhere near kind of the evidence base, I think, in terms of we had for tobacco on alcohol. We know alcohol is very harmful, but there's still a lot of kind of feeling that, there are benefits socially, etc. And whether or not that's true or what your beliefs are kind of irrelevant. The point is that for some people, alcohol causes massive harm. And it's just another drop, but it's also about the ripple effect. And we talk about the ripples into society and the families it damages and the children it impacts. And we ask in the report how we can make it easier to talk about and make it easier to help people and to broach the conversation without sounding judgmental or preachy. So yeah, it was a hard thing to do, to be so open about something so personal. But after I did it, the number of people who messaged me to say it touched them, or that they too had had the experience but had never felt able to talk about it. There's a lot of shame carried by people. There's a lot of embarrassment for people who've had relatives that do it, or a lot of despair because they weren't able to help. Families are often estranged. They don't talk to other members of their family, or they've watched them die. And the number of people that said, thank you, because it's made me feel that I can talk about what happened and that I will be able to share this impact upon me. And, if it did nothing else, it allowed some people in this county to be able to say, alcohol hurt me. And I think that was really, really important. Somebody also said to me, it made me seem human, and it made them understand that I wasn't just this person who'd done a degree and studied in an ivory tower and I was telling them what to do. That I was actually coming from a place of kind of genuine understanding, and that life's complex and people do things and no one's to blame for that, but it does have an impact.
Yeah, and you're just a real person.
Yeah.
Yeah, like I said, thank you. It is, yeah, I personally think you're extremely brave to do that. Very vulnerable and brave just to get out there and talk about it and allow people to, feel the way that they're feeling and not push it down and hide it. So, no, thank you. One thing that we spoke about, and I think it's really important, is when we discussed your public health journey, right at the start of our conversation, you were like, I wasn't too sure if I wanted to be a director in public health. And now here you are, doing so well. What changed for you in your journey to go, yeah, actually, I want the job?
Yeah, I mean, in some respects, it was probably COVID, because I think I wasn't sure when I came down to be deputy DPH, I think a lot of other people had said, have you thought about being a DPH? And I always said, I'm not sure, don't really know. And I think there's two parts. I wasn't sure I wanted to, and I wasn't sure I could. And I think after COVID, if you can kind of go through COVID and you can manage how challenging that was, and the volume of work and the intense pressure and the moral hazard that you have of making the right decisions for the population and doing the right thing, and doing that carefully and mindfully, I sort of figured, well, what is there in the day job, the normal business as usual, that could be any harder than that? Is there anything that could be harder than that? So I think, well, if I could do this, I could do the day job. So then there was the question about, did I want to? And I think what I started to realise was that, if not me, then who? And Sarah at the time was thinking about stepping up further into the organisation, and releasing the public health role. So there was a conversation here about, would I consider applying for the role if it became available, and did I want to do it? And I sort of just said, well, yeah, I guess I do. And I think the more I thought about what that would enable me to do, which would be to lead the way I wanted to lead. And, Sarah was a great boss, but we are different. We are different people. And I have a slightly different style to her. And to actually be given that opportunity to say, okay, you're right, find your style, do it, do what you think you need to now do for the population. And I realised that, there's 150 or so local authorities in England. There's also obviously the devolved nations as well. But in terms of England, there's about 150 direct public health posts. And every single post is different because every single council is different and every single person doing the job is different. So it was feeling that ability to say, actually, I have skills to bring to this. They're not the same as Sarah, but that's okay. And I will do a good job, and I want to do a good job, and I want to make a difference. And when you're the director, you have that choice. You get to do the choosing. You get to say, actually, Sarah, that's a great way to do it, but I'm the director now, so I'm going to do it my way. So that's been really empowering, and so I think it's just that bit about if you can be a competent consultant in an authority and you enjoy the work and you think that you might know some of the answers, then go for it. Yeah.
Because I think you mentioned when we were talking about Salford again in our previous conversation, it was like find the role that suits you. So even if you haven't gone through COVID, but like you say, there's 150 different opportunities.
Yeah.
Finding that role, could you just briefly touch on that? Because I thought that was actually really interesting for you to say.
Yeah, so some directors of public health do very specifically only public health. Some directors of public health have other services with them and that are kind of aligned to public health or are part of the public health role in some respects, so environmental health. I'm in a county council, which we're actually going through local government reform at the moment, so there may not be county councils in future, but working in a county council is very different to working in a unitary council where all the services sit together, whereas instead of one housing team, I've got 6 housing teams to work with. So actually this role really suits a director that's quite collaborative and really likes partnership working and really enjoys kind of bringing people together and can make sense of 6 different ways of doing things and find the way forward. So that's been, I guess, one of the skills I have brought. And clearly through COVID, we built our relationships with the districts hugely, and particularly our environmental health teams. And we've done some really interesting things here, like decide to pay a little bit extra to one of the districts to do some leadership for the whole of the districts around environmental health. And that was something we came up with as an idea. One of the district chief executives, and I said, yeah, let's do it. So again, that's the ability of being the director, is you get to go, yeah, let's do that. Let's do it. Yeah, I've got the budget. I can decide that. So that's really cool. So yeah, I think it's that bit about where suits you. Who are the people around you? You know, what are they like? What other services do you have? What's your career direction in future? You know, you might want to do a job that's got, I think there's the DPH in Stoke, for example. I know Stephen well, and I think he's got a very wide portfolio, for example, and something like that might suit somebody. I don't know Stephen's ambitions, but might suit somebody who's going to be a chief executive in future, for example. Whereas other jobs are much more around a sort of technical day job. And that's the beauty of the career, really, is it's lots of different things.
It is, yeah. No, I just thought it was really interesting for you to say, like, someone might think it's just a director in public health, and no matter where you go, it's the same job. But like you say, different councils, different locations, just the collaboration is very different. So if it's not right for you in one place, it could be right in the other. Also, I just wanted to touch on support networks. So when you said sort of like, oh, I didn't know if I wanted to be a DPH, and then you did step up, you did mention a couple of things around, okay, so like what or who did you or do you still use to help with that, to really support you in your job and you to become a DPH?
Yeah, so most consultants will have the opportunity to apply for leadership schemes. There's one that's been running for a very long time, which is called I used to be called the Aspiring Directors course. I think they may have changed its name, but it's essentially a nationally run program. You apply for a place, and then there's a cohort of consultants that get onto the course. They've widened it slightly so it can be aspiring directors in local authority, which is actually quite nice because you get that variety of different experiences and backgrounds. That course takes you through some theoretical work about leadership, gives you a chance to reflect. You do some interesting 360 feedback, which is an interesting process. It's a narrative feedback. So you actually have a conversation with somebody rather than a tick box about your style, which is really interesting to do, actually, and quite humbling when you get the nice feedback as well. And then as part of that, there was an action learning set. So we carried on our action learning set after the course for 4 years now. So they're my peers in this world, and that's a really safe space where we talk about ambitions, challenges, barriers, things that are troubling us, next steps, etc. So that's great. And then when you step up to be a Director of Public Health, the ADPH Association of Directors of Public Health have a mentoring scheme. So more experienced Directors of Public Health give their time to mentor newbies and help them through some of the challenges they're facing. And you kind of get a chance to say, I'd like this sort of person to match with, and they match you across the country. And then there's always opportunity through work to do other leadership training or coaching. Really important. So it's probably the main ones.
And then was it the Southwest? The Southwest are quite...
Yeah, we have it's a really good point. So we have a network across the Southwest region of all of the Directors of Public Health, and I'm just really lucky that I haven't worked as a director in other regions, so I don't know what the networks are like, but I can say that we really are, they call us a public health family, and it does feel like that. We are, we are really, really close. We work really closely as a set of directors across the region, but we also work closely with UK Health Security Agency and the Regional Director of Public Health as well. And recognise that, actually sometimes other areas are doing things better. We have quite good sector-led improvement where we learn from each other and improve our practice, and are open and honest and share what's gone well and what hasn't gone well and how we can improve. So kind of culture of learning. Lovely.
It's nice to hear, because I think when you get to that level, I think people would always assume that you know everything and that you don't actually need support when you're at your level. But I think at every level, to have people around you to validate you internally, externally, have peers that you can sort of bounce ideas off of, take feedback, implement change, I think it's really important.
Yeah, and then I think public health, there is no right answer a lot of the time to the things we do. There are lots of different ways of doing it with pros and cons, and you have to make a decision about those pros and cons. And when you're making that decision, sometimes having a phone a friend, DPH phone a friend, is always nice. So occasionally I call in my phone a friend favours.
Nice. Final question. For anyone in public health or sort of going into public health, what would be like the one piece of advice that you would give someone?
Yeah, I think the one piece of advice for people not in public health yet, but interested, I think there's a fear that if you're not in a public health team, you're not going to be able to get into public health in the future. And I just don't think that's true. So if you look at my career, it was research and it was working in health promotion. It wasn't public health at the time. It was in the NHS. It was in health promotion. It was skills that were really important for public health in the future. So you could work in a voluntary sector organisation. You could work in a care home. You could work with children and young people. You could, be a youth worker. So there's loads of different things that people do. You could, talk about geography. You could be we've got a lot of people coming on the training scheme who've been kind of in geographical jobs doing maps and looking at populations. You could be a statistician. And one of the very senior consultants in Wales, I think, was a communications background. So it's about transferable skills. It's about an ability to understand that this is a values-driven job. You have to want to make a difference. I think keep aware of the news and understand what the public health issues are out there, but don't worry that you've not worked in a public health team. That's not the be all and end all. Find something you enjoy doing where you're making a difference and learn how that relates to public health. And that's, I think, how you get into public health in the future.
Nice. What about someone who is in public health? Was it?
Someone who's already in public health, perhaps a consultant who's thinking about stepping up. I think it's have the confidence. If not you, then who else? Everybody comes with different skills, and what I've really learned, one of the things my mentors told me is, he says, you be you, everyone else is taken. It's really valuable to remember that, because you do bring skills to it. And as we said, different jobs suit different people. So find somewhere where you match, use those skills. And I think it's a great career to do.
Lovely. Thank you, Siobhan.
Thank you.
It's been an absolute pleasure. Thank you so much. Thank you for listening to our Public Health Spotlight podcast, brought to you by Panoramic Associates and partnered with the ADPH. Tune in for our next episode.